being a digestive oncologist, I'm working with immune therapy, mainly checkpoint inhibitors, both in gastric cancer and colon cancer, and a little bit in cholangiocarcinomas. But it's for most cancers, it's for MSI high patients. So there we really know that checkpoint inhibition works in monotherapy usually. We also had recent data of a combination therapy of anti-PD-1 and anti-CTLA-4 in colon cancer patients in first line that were very, very promising. So we know that the MSI high phenotype is really the phenotype of patients in GI oncology that benefits most from checkpoint inhibition. And we also have combinations of chemo plus checkpoint inhibition in gastric cancer and in cholangiocarcinomas. And there we have to look for a certain profile. So we check for the CPS score, which is a score of PD-L1 expression, and the ones that have a higher expression, they usually perform better. But we really don't have any nice data in pancreatic cancer. As I said, we have a little bit of patients with MSI high profile, but it's less than 1% of patients. So we really have to look for them. And even if we treat those patients with checkpoint inhibition, it doesn't perform as well as in other GI tumors. That again is probably because of the stroma. So there's a dense core around the tumor, and it's chemotherapy reaches the tumor not that easily, and immunotherapy is probably the same. So we really need to tackle to work both on the access of a therapy to the tumor and the therapy itself.